Alright, once again we have agreed to gather this morning to finish this unfinished part of this thoracic wall and the content of it. Before we go for the content itself, we just have a quick recap whatever we have done previous day. We learned this particular thorax having this kind of boundary which is present on it. We call them a thoracic wall, and this particular thoracic wall is made of two different kinds of bones, cartilage there. We call them as sternum, ribs, which is united together on the back side by this vertebra, and between this particular ribs and the sternum we have this blue tissue. We call them as cartilage, we call them as costal cartilage. They are uniting and making this particular bony cage or rib cage, and these landmarks are familiar with us, whatever this landmarks is related to it. We learned this particular landmarks, how this particular landmark matters, we talked about, and we enter to this particular space, we call them as intercostal space, which includes some soft tissue structures, muscles, nerve, vessels, etc., etc. We agreed that we learned that this have got three muscles present in it. We call them as external intercostal, internal intercostal, and innermost intercostal. And the functions of this particular muscle to give stability to the rib cage whenever it is making some kind of movement like breathing in, breathing out. And these particular muscles are giving this texture so that this particular lungs, whenever it is pumping the air in and out, it is not blown out. So this is the functions of this particular thoracic wall muscle. Now this particular external muscles or intercostal muscles becomes functional whenever you are exerting this particular movement of the chest walls. Whenever you are breathing really deep or breathing really high, then only this particular muscles really makes contractions and helps us. Then we learned about this particular figure, we call them as dermatome or dermatome pattern of the skin, which is the skin innervation or sensory innervations of this particular trunk or this particular upper part of the trunk. We call them as the thorax. Now this particular dermatome pattern comes from this particular nerve supply, from these particular nerves. We call them a spinal thoracic nerve, and the spinal thoracic nerve, which is in this particular region included or covered within this intercostal muscle, we call them as intercostal nerves. Now these intercostal nerves have got the branches which supplies this particular skin and along with the pleura which is adjacent to it, and it supplies these intercostal muscles. So this particular skin dermatome comes from the cutaneous branch of this intercostal nerve and supplies in a pattern which is universal. So every body have got same kind of nerve supply which is present in it, and we can figure out by this particular tracking this particular dermatome patterns like the nerves which is present on here can figure out which particular area of the skin is supplied by which segment of the spinal nerves, and which helps us to figure out some clinical problems, diseases, etc., nerve error or any kind of infections related to these particular areas. Now this particular nerves is placed between this particular intercostal space, and it has a particular lodging. It lies under this particular rib, and under this particular rib we have a groove, we call them as intercostal groove. Within this particular intercostal groove, along with these particular neighbors which they have vein, artery and the nerve, they are placed. And now this particular structure, vein, nerve, the vein, artery and the nerve, they have a particular pattern how they are present on it. Above to down we have this vein, then we have the artery and the nerve which is hanging at the lowermost part of this particular space, we call them as intercostal groove. Now having this particular nerve placed at this particular lower bottom end helps us to catch this particular nerve, especially whenever you are trying to anesthetize. We call this particular nerve anesthetize procedure as nerve blocking. So whenever you are trying to get an anesthesia, catching up these particular nerves, we put this particular drug fitted with this particular syringe, pierce this particular muscles and reach to this particular plane where these particular nerves are placed, which is placed between this particular innermost internal intercostal and innermost intercostal, and that particular muscle plane we pierce that particular space under to this particular costal groove and throw the drug and wait for some times and get this desired anesthesia if it is required to. So this particular knowledge of this intercostal nerve block is kind of important for us whenever we are going to do any surgery. And apart from that, we have a disease, we call them as herpes zoster, that travels along the nerves, intercostal nerves maybe, or any other nerves. So if it is following through this particular intercostal nerve, catching up to this particular segment, it follows the dermatome pattern as this particular blisters or this particular eruptions comes along. So this particular eruptions follows this dermatome pattern whenever this particular discharge or the toxins coming from this herpes infections. So we call this particular herpes zoster infections, which is very painful because of the blisters, which is liberated from this particular virus toxins, which is kind of like a very diagnostic thing for us. Now from this particular content of this particular nerve, we are going to learn about other things which is present within this intercostal space. So this particular intercostal space also have this particular arteries or two sets of the arteries which is present in it. And this particular simple diagram helps us to identify what are the arteries that is present through this particular intercostal space. So this is a strip top typical intercostal space that you are seeing here. This is the back side of the vertebral body, this is the front side sternum over there. So this anterior part of the intercostal space, and this is ending up to the part which is posterior part of the intercostal space. Now if you have a close look on it, we can see that there are two sets of the arteries which is getting into this intercostal space. One from the anterior side, other is from the posterior side. And these particular intercostal arteries, accordingly how they are penetrating to these intercostal spaces, we name them anterior intercostal artery, posterior intercostal arteries. Now if you count the numbers, if you look at this in the back side first, this is a single artery which is coming and entering to the intercostal space. So we have each intercostal space fitted with one posterior intercostal artery, which is coming from a branch of artery which we call them as aorta, and this part of the aorta we call them as descending thoracic aorta. We are going to talk about it. So this posterior intercostal artery coming from some aortic branches getting into it, and this is single in number. Now from the back side, if you look to this front side here, we have anterior intercostal artery entering to it. So this artery which is coming in here, we call them as anterior intercostal artery. Now this anterior intercostal artery, if you see the numbers, this is one, this is another. So you have a pair for the each of the intercostal space, right side and left side. So these anterior intercostal arteries, they are paired compared to the posterior one, they are single. And this particular anterior intercostal artery is coming from an artery, we call them as internal thoracic artery. We will learn about internal thoracic artery very shortly, about this particular course and everything, because this internal thoracic artery, we do this particular artery for making a dissections, and we do identify this intercostal artery for some clinical reasons as well. So this particular anterior intercostal artery, there are two above and below within this particular intercostal space, they are coming and entering to it. So this anterior intercostal artery is two and posterior intercostal artery, they are one. They travel along this particular space where this particular intercostal arteries are placed, as you have seen these particular positions of the intercostal arteries. They above downwards, vein, artery and nerve, this is how they are traveling. So this above one is vein, the middle one is the artery, intercostal artery of course, and this one is this nerve which is present in here. So this particular artery is placed between this particular vein above and the nerve and travel along each of these intercostal space. The posterior one is the larger one, the anterior one is the smaller one. Now what happens here is the posterior one splits down into a branch, we call them as collateral branch, and this particular posterior intercostal artery and the anterior intercostal artery reaching to some space within this particular intercostal region, they join with each other, we call them as anastomosis. So this particular anastomosis happens between the branches of the posterior intercostal artery and anterior intercostal artery. Now time have come to little bit more to learn little more detail about this individual of them. Like that, this posterior intercostal artery, as we have said, it is single in number. The majority or 11 pairs, whichever you are saying here, is coming from a source artery, which is coming from the posterior side. We have in the back side to the left side of the body, we have a descending artery. We call them as descending thoracic aorta. Now this descending thoracic aorta principally sends all the branches to these posterior intercostal spaces. So posterior intercostal artery, largely majority of them is coming from descending thoracic aorta. Like if you count the numbers from above down, number 3 to 11. So it is majority of them is coming from the thoracic aorta. only the number 1 and number 2 posterior intercostal artery coming from a different branch, we call them as superior intercostal artery, which is a branch of costocervical trunk. So, having said that, if you are finding difficulty in memorizing this small thing about this particular costocervical branch and where from this particular posterior intercostal artery, do not remember. Please do remember this one thing for the source of this posterior intercostal artery as descending thoracic aorta, which is giving a branch to this all the posterior intercostal artery except 1 or 2, which we do not remember. So, the prime thing is you should be remembering this descending thoracic aorta, sending the branches as posterior intercostal arteries. This 1 and 2, if you forget, no harm. So, this is about this particular posterior intercostal artery, and this particular posterior intercostal artery accompanies the vein like vein, artery and nerve, which we have discussed, and this is a longer one and it runs to this undersurface of the rib, we call them intercostal groove, and ends by anastomoting with anterior intercostal artery. So, it comes over here and sends some branches, we call them as collateral branches, and this particular collateral branches join with these anterior intercostal paired branches, and this particular union we call them as anastomosis between the anterior intercostal artery and the posterior intercostal artery. Now, coming to this particular anterior intercostal artery. So, anterior intercostal artery, they are paired coming from this artery which is hanging down by the side of the sternum. So, by the side of the sternum we see an artery going down in a straight way. We call this artery is internal thoracic artery. So, this internal thoracic artery, as it is coursing down by the sides of the sternum, right side and the left side, each of these particular spaces of them are receiving this particular anterior intercostal branches. They are coming from here and reaching to this particular anterior intercostal space. So, this particular anterior intercostal arteries, they are paired and coming from the branch, we call this as branch as anterior intercostal artery. So, internal thoracic artery. So, what is internal thoracic artery? So, we have an artery which is coming from this artery, we call them as subclavian arteries. The subclavian artery first part sends a branch which goes down by the side of this sternum on the right side and the left side. So, as it is growing down from this internal thoracic artery, it is coursing down above to from this particular subclavian artery and coursing down by the side of the sternum and ending into splitting into two terminal branches. We call them superior epigastric branch and musculophrenic branch. So, this internal thoracic artery is a branch of first part of the subclavian artery, and then after giving this particular branch, it is coursing down or coming down straight on the right side and left side. We have two of them are there, internal thoracic arteries. So, they are coursing down by the sides of the sternum, and each of these particular spaces, it is sending two of these branches, we call them as internal thoracic artery. Now, how this internal thoracic artery end? It splits into two terminal branches. That means reaching over here, it sends into two branches. One branch is going to this abdomen or anterior abdominal wall. We call this branch which is entering here in the anterior abdominal wall, we call them as superior epigastric artery. In abdomen, we are going to talk about it. Now, other branch which this particular internal thoracic artery terminally splits into, we call them as musculophrenic artery. Now, the word phrenic is related to the diaphragm. So, this particular thing supplies the diaphragm, a part of it. So, this musculophrenic, which is one of the terminal branch, runs all along with this particular region, coursing here, end up to supply the diaphragm and sends this rest of the branches to this particular internal thoracic artery branches, to this particular anterior intercostal artery branches, to this particular lower intercostal spaces. But to just like make it short, we have this particular anterior intercostal artery and the posterior intercostal artery. Posterior intercostal artery are primarily coming from this particular branch, we call them as thoracic aorta, and they are single in number, they are larger in length. And anterior intercostal artery, the majority of them are coming from this artery, we call them as internal thoracic artery. They are paired, two in number. In each of the spaces, they are going in this particular way. This internal thoracic artery is our exam ID. For the examination for this particular in the lab, dissection lab, we dig out this particular artery, and if that artery is present on the specimen, we tag it for identification. Now, why this particular arteries or internal thoracic artery or anterior artery important? Now, these particular arteries are kind of and arteries which having a particular caliber and which has a particular tensile strength. So, this particular having a particular girth and particular tensile strength qualifies this particular artery to be taken for the arterial grafting. Now, when this particular arterial grafting is required, whenever we have a clogged or blocked artery in the heart or heart muscles. In the heart, which is supplied by arteries, which is supplying the heart musculature, we call these particular arteries as coronary arteries. Now, these coronary arteries may be clogged or blocked by some kind of materials which is fatty or some kind of plaques. So, in some of the regions, if that particular coronary arteries are superiorly clogged or very much clogged, we may have to prepare a bypass tract or bypass route so that that particular clogging or blockage can be bypassed. So, for that we create a bypass tract, and that particular creation of that bypass tract we call them as coronary bypass surgery or coronary bypass grafting. Now, we have to create a bypass tract by replacing or making a new way or new arterial way. So, for that we need some kind of arterial grafts. So, this particular arterial grafts we have to take from some other parts of the body. So, we have many arteries in our body. These particular arteries are subcutaneous or just like below this particular region we have this particular intercostal spaces, easy to dissect out, and we can take this particular arteries out because we have a pair of arteries there. So, we have this particular intercostal arteries, and this particular intercostal arteries have got two sets are there. One is coming from the posterior, one is coming from the anterior sides, and this anterior one is coming from this internal thoracic artery. Now, this posterior one and anterior one are mingling with each other. Now, this posterior one is larger, the anterior one is smaller. So, as a result of that, we can take out this particular arteries for the grafting because we have a posterior set of arteries. Even we take this particular artery for grafting reasons, this particular posterior intercostal artery can take over and supply this region. For having this kind of like abundance of co-lateral circulation which is present in these intercostal spaces, we have a luxury of picking up these particular arteries for grafting. Now, this kind of grafting we call them as arterial grafting. That means we take the artery, separate it out and place it somewhere if it is required to. Similar to that, if you take this some kind of skin, we call them skin grafting. So, this kind of arterial grafting can be done from these intercostal arteries. Anti-intercostal arterial branches are the prime thing which can be picked up, along with this internal thoracic artery as well, or the right side can be picked up or left side picked up for this particular arterial grafting reasons. So, these are the clinical points related to this particular intercostal arteries. Intercostal arteries itself also is an exam short note. So, we can prepare these or we have to prepare these intercostal arteries for the exam as well. From the arteries we are ending up into these veins. So, corresponding to the arteries we have the veins. We have the anti-intercostal veins, we have the posterior intercostal veins. So, anti-intercostal veins follows this particular likewise the anti-intercostal arteries. So, anti-intercostal veins runs to the anterior intercostal vein to the internal thoracic vein. So, they dump this particular blood from anti-intercostal vein to the internal thoracic vein to the brachiocephalic vein likewise. So, this is how this particular anterior intercostal veins drains the blood from this particular region. Now, for the posterior intercostal vein, it is little bit complex. So, to have a visual of things, how this particular posterior intercostal veins drains the blood from this particular space. Now, you see that this is everything stripped off and we have a set of veins which is presented over here. So, we have a spider wave kind of veinar network which is present in here, which is really complex. Now, you see that on the right side we have a set of long veins and the left side we have a fragmented venous networks. Now, this particular long chain of vein which is coming down and reaching to this particular superior bigger veins, this vein we call them as azygos vein. So, this right side of the thorax on the posterior side we have a vein we call them as azygos vein. Now, all these posterior intercostal veins directly or indirectly drains into this particular azygos vein. So, this particular azygous vein on the right side receiving all the tributaries or the tributaries from this particular posterior intercostal space. You see that these numbers are there 2, 3, 4, 5, 6, 7, 8, 12. All of them are draining into this vein at their respective levels, ending into, so the blood from the posterior intercostal veins dumps into azygous vein. The azygous vein drains into a bigger vein. We call them as superior vena cava. The superior vena cava ends into right chamber of the heart and dumps the blood into heart, and which is again pumped out to the lung and recycled back. So, on the right side we have this azygous vein receiving all the tributaries which is coming from the posterior intercostal venous tributaries. This is how it is then, except one. You see the number 1 is draining directly to a vein which is going to form this superior vena cava. We call them as brachiocephalic vein. We will be coming into brachiocephalic vein very soon. This right one on the right one, number 1 is draining differently. So, the venous drainage on this left side is majoritarily is draining into azygous vein. If you remember this azygous vein, that is good for us. For the left side, it is complex. You see that in the left side 1, 2, 3, 4 and then 5, 6, 7, 8 and then 9, 10, 11, 12, they are different. So, you see that this particular left side also eventually drains into the azygous vein. So, this lower half uniting together makes a vein, we call them as hemiazygous vein. And what they do? They cross over and eventually drains to the right side azygous vein. What happens to the 5, 6, 7, 8? They make another united vein over there. We call them as accessory hemiazygous vein. But eventually what happens to the accessory azygous vein, hemiazygous vein? They cross over again and joins to the azygous vein. So, you see that the left side as well, likewise right side eventually drains to the azygous vein and dumps this blood from the left side of this intercostal space posteriorly drains into this azygous vein, except this one, which is 1, 2, 3, 4. They make a kind of united vein. We call them as left superior intercostal vein, and they directly drain into this bigger vein, which is known as the brachiocephalic vein of the left side. Now, this much of complex thing we cannot remember. It's not possible for us to remember all these things unless until you are doing exercising this only one thing again and again. So, my recommendation is that for the drainage of this particular intercostal vein on the posterior side, for the posterior side, we memorize only the directly or indirectly drain through azygous vein and empty the blood. So, if you remember that particular word azygous vein, this one name saves us for making this particular story complex, because we have to learn too much of information. We cannot analyze and prepare or preserve too much of information. So, a relevant catch point is that the posterior intercostal vein directly or indirectly they drain to this particular azygous vein and empty the blood into it. So, through this accessory hemiazygous or hemiazygous, they eventually drain to the azygous vein. But one thing you have to remember about out here is that this particular venous channel is the azygous vein. Again, this is a short note. You can see that because it drains, receives all of it, and it has a connection which is extending from this particular vein. We call them as lumbar part of this particular vein. This vein which you are seeing here in bottom, this is a vein we call them as inferior vena cava. And this vein which you are seeing here, we call them as superior vena cava. So, SVC and IVC. And if you just like follow this particular azygous vein is a bridging vein between these IVC to SVC. And in between them, whatever things are like a tributaries of the veins are there, it is dumping into it. So, it's a kind of like a kind of connection between SVC to IVC which is existing in this particular region, and that makes this particular vein really, really special. So, azygous vein we have to learn in detail whenever time comes to learn about it. From these veins, we move to the lymphatics. It's easy. We have two lymphatic groups which is present. One is in the anterior side of the intercostal space. One is to the posterior side of the intercostal space. Anterior one we call them as thoracic group or internal mammary or internal thoracic group of lymph nodes. Posterior one we call them as paravertebral because they are by the side of the vertebra. And this particular lymphatic receives the lymphatics from the thoracic wall and drains to the higher group of lymphatic channels and eventually drains to a lymphatic channel. We call them as thoracic duct. We will talk about thoracic duct very soon. So, this particular intercostal lymphatic drainage is pretty easy for us. So, summarize the content of it. We have 3 sets of muscle: external intercostal, internal intercostal, innermost intercostal, and in between we have the space. In between them we have this particular neurovascular structure running over there, and this particular neurovascular structure we call them as intercostal artery, vein and nerve, and they have a particular place over these particular regions. They have a particular plane to run over there, and we learn about the detail of this particular thing. These arteries, these particular veins, and this particular nerves which is present, along with the lymphatics which is present in it. Now, from these particular regions we move to these particular movements of this particular thoracic cage or chest wall movement. So, whenever we are taking some kind of respirations, breathing in or breathing out, we have this particular chest cage or this particular thorax wall moves into particular directions. So, if you have observed or if you are observing, this particular movements of this particular thorax or chest wall can be classified into 2 different kinds of movement. So, one kind of movement is that part of this chest wall moves more anteriorly or anteroposterior movement is high, and other types of movement we see that there is a lateral expansion of the chest wall or thoracic wall is there. So, there are 2 basic kinds of movement is observed whenever we are breathing in or breathing out. One is the anteroposterior, anterior to posterior, that means vertebra to sternum, that kind of expansion or recoil is there, and the other one is lateral, that means the sideways it is expanding and shrinking. So, these are the 2 basic kinds of thoracic or chest wall movement is observed. Now, there is another type of movement, we call them as pump handle movement, which is observed within this particular movement of the diaphragm. So, as we are breathing in and breathing out, the diaphragm which you have either going up and going down, just like a piston, we call them as vertical movement. So, this particular vertical movement takes place within the diaphragm, that is not restricted to the or related to the chest wall, but though it is helping out the respiration, we can call it as respiratory movement as well. So, we have this particular thoracic wall, the bony part moving into 2 different directions, anterior posterior directions and the lateral directions, and this particular movements is easily narrated in a way we call this kind of movement changes into these ways. We call them as pump handle movement. Likewise, the handle of a pump moves, and bucket handle movement, the handle of a bucket it moves. So, if you have projected this particular pictures, how this particular movement helps us to identify, it will be easier for comprehending this particular movement whatever we are seeing here. Now, if you pay attention to this particular picture, that helps us to identify what do you mean by this kind of anteroposterior movement and lateral movement, and these are very simple things which is related to it. Now, first we take this particular movement, we call them as anterior posterior diameter expansion or AP diameter mention. That means, if you are measuring from the vertebra to the sternum, that particular line if you are joining, that is anterior posterior directions. So, for sternum to the vertebra, that is the anterior posterior, and the sides from the right side of the rib or left side of the rib is that transverse diameter. So, there are 2 diameters which can be measured in my thorax wall. Along with that, we have oblique diameter as well, but we are disregarding the oblique thing. We are only emphasizing this anterior posterior, just like we talked about in skiagram or taking this and lateral views. So, transverse diameter and anterior posterior diameter we are emphasizing out here. Now, whenever you are taking this movement, we take one at a time. We take this particular transverse diameter later, we will take this particular anterior posterior diameter expansion first. Now, we call this anterior posterior diameter expansion by narrating this particular movement comparing with the movement of the handle of a pump. Now, what is a pump? This is an old fashioned pump. So, we have this particular tube well pump, we have a handle and we have to just like pull up and down to just like fetch some water. So, this kind of handle is there and we are lifting it and putting it down. Now, we have to compare this handle with some part of our body. Now, some part of the body means the some part of the chest wall, which is this particular sternum is. So, imagine this particular sternum as a handle of the pump and we lift it. So, if you lift this particular sternum up, we increase a diameter. This particular diameter gets expanded, which is running into this way. So, this particular axis, if it is moving, holding this handle of the pump, which is the sternum, and lifting this thumb, this increases this anterior posterior diameter. So, this kind of movement which is happening in the upper 6 ribs We call them as pump handle kind of movement, and with this pump handle movement we achieve an increase or expansion of anterior posterior diameter. Clear? Now we move to the next part. This is a bucket and this is a handle of bucket. Now if you are holding this bucket handle and grabbing it and try to lift it up. So you are holding it and trying to lift it up. This particular handle of the bucket, you are holding it. So this particular handle of the bucket is emerging with this lower 6 ribs. We are holding the sides of the ribs like right side, left side, and then grabbing it and lifting it up. So if you are lifting this particular sideways of it, you are lifting these things up and pushing this or putting these things away. So this lateral one, if you are lifting this, you are expanding the transverse diameter. So this happens in the lower 6 ribs whenever you are making a movement of this particular lifting this lower 6 rib laterally and increases the transverse diameter. So upper 6 ribs moves in a different direction and lower 6 ribs moves to a different direction, different axis, and eventually we achieve an increase in the whole thoracic cage, increase in diameter anterior posterior as well as transverse diameter increase. So this kind of chest wall movement is achieved by the pump handle kind of movement, and bucket handle of kind of movement is nothing but expansions of transverse diameter and the anterior posterior diameter, which is achieved by some kind of muscular contractions whenever we are heavily breathing in or breathing out. So anterior posterior diameter increase, which predominant ribs are working here, upper 6 ribs. And what kind of movement is going on? Pump handle kind of movement. What is going on? The sternum is lifting up. So this particular thing is lifting in the anterior posterior diameter. We get an increase in anterior posterior diameter. So there is an expansion of chest wall. Transverse diameter, what happens over there? You have a bucket handle kind of movement. Which ribs participate in it? Predominantly we have the lower 6 ribs working in here. We have expansions of the transverse diameter. We have increase in transverse diameters. Now third thing, which is not related to this particular bony cage but related to this vertical diameter expansions. So whenever you are breathing in and breathing out, whenever you are breathing in, the air is getting inside the lung. Now what happens whenever you are breathing in, the diaphragm contracts. So diaphragm is a structure which is having two kind of domes or bulge. The central part is like this and it has a bulge like this. So whenever his diaphragm is contracting, it becomes flatter. So when it becomes flatter, it moves down. So if it is going down, we are achieving a diameter increase in vertical directions. So we have an increase in vertical diameter with the descent of the diaphragm during inspiration whenever it is contracting. So by these 3 mechanisms, we are increasing or squeezing this interthoracic space. Now when this particular interthoracic space matters to us, this interthoracic space matters to us whenever we are breathing in, breathing out heavy. Now what do you mean by that? Right now you are sitting idle, you are not doing any exertions. Right now you are breathing quietly. Now during quiet breathing, which you are doing right now, we do not have any such a movement we are observing. Now what happens when a quiet breathing? We have this particular very few muscles are working on it. So whenever you are quietly breathing in and breathing out, normal respiration, it happens because of the contractions of the diameter. Only the vertical diameter changes. So diaphragm contracts, it goes down. That means we have increase in the vertical diameter and we get the space for the expansions of the lungs. Lungs fills the air with the negativity inside, air sucked in. And then what happens once this particular desired level of this oxygen is achieved, the diaphragm stops contracting and then it relaxes. Now once these things are exchange of the things is done, the lung tissue itself has a capacity. That capacity of the lung tissue to squeeze itself, we call them as a recoil of the lung. So once this lungs expands, it shrinks. So that shrinking of the lung, we call them as a recoil of lung. It's not related to any muscle. The lungs has some kind of connective tissue which is known as elastin, collagen fiber kind of things which is known as elastin and recoiling things which is present in here, and with this particular thing which helps us or gives this particular lung to this elasticity, stretching and unstretching thing. So this particular lungs, once it's expanded, it cannot remain there, it recoils. The lung itself pushes the air out. So when you are throwing the air out or breathing out, There are no muscle contractions is going on there. Only lung recoil is happening. And when you are taking the air in, like what now you are doing, you are only exercising the diaphragm. Clear? This is what, now imagine yourself running and rushing and doing some kind of exertion, climbing the stairs, climbing mountains. Then you need extra bit of air. Then you need more air because you are doing more work. You need to burn more glucose, you need to burn more carbohydrates, more fats and proteins, etc., etc. So, we need more air to combustion this. Then we need more air. For that reason, we have to expand lungs rigorously. You need more air in a quick fashion, in quick time. Now, normal breathing rate is like 15-20 cycles in a day, in a minute. That particular cycles may become 60. That means you are breathing 60 times in and out whenever you are exercising. So, for that reason, you need extra power. Where from this power is coming? For the contractions of the skeletal muscle. Then which muscles are contracting? Intercostal muscles are contracting. Chest wall muscles are contracting. So, whenever you are breathing heavily, we call them as forced or assisted inspiration. Need to breathe more air in. We need to recruit some of the chest wall muscles to do the job. Pectoralis major, pectoralis minor, serratus anterior, sternocleidomastoid, scalene muscles. These are number of muscles which are helping out to expand this lung. And what they are doing? They are laterally moving this particular diameter way by this making the contraction. That means they are making the bucket handle movement. They are breathing in, breathing out. That means they are making this pump handle movement through this particular different kinds of muscle recrusions. And they are increasing or stretching the diameters. So, at that time we have three different kinds of diameter expansions going on, which is visible, which you can see. So, this particular anteroposterior diameter increase, transverse diameter increase and the vertical diameter increase happens in the same synchronized way, so that we can get more air in and out. So, this particular extra muscles is working on here to increase this particular thing. Now, whenever you are breathing out, that means you want to throw all the air out, whatever it is there. We need to recruit some of the extra muscle from the abdomen. So, right now you are breathing in, breathing out with the elastic recoil. Now, you have still some dead air left in the lung while you are breathing quietly. So, you want to throw all the air from the lung. So, for that you need to recruit this anti-abdominal wall muscle. We can have this anti-abdominal wall muscle. Likewise, this anterior thoracic wall, they are contracting that time and throwing all the air out. So, this heavy breathing, forced expiration and forced inspiration requires this muscle action, and this particular required muscle actions makes this particular diameter changes, and this particular increase in thoracic diameter helps us to breathe more and get the more air if it is required to. So, this kind of movement, as you are seeing here, pump handle, bucket handle and this particular vertical diameter increase, piston movement of the diaphragm going on to help us in the respiratory. So, these are the three basic kind of respiratory movement of the thoracic wall. So, whenever it is given, this is also an isolated short note, we get it. So, for this we do not expect something complex which you need to explain about this particular diameter increase. We have to see that what things are there, what are the different kinds of movement and what we achieve by doing this. So, we achieve this particular pump handle movement. By this is we increase the anteroposterior diameter, and this particular anteroposterior diameter is predominantly taking place within the upper 6 ribs. We achieve this transverse diameter increase in case of this bucket handle movement. Bucket handle movement is primarily done at the lower 6 ribs and vertical movement diameter, etc., etc. And what are the extra muscles which are doing and helping out to achieve this kind of respiratory movements. So, this concludes us for this respiratory movement and the accessory muscles of the respiration with the movement of the diaphragm. It is going up and down, how this particular things is helping out. Now, this is known as dyspnea. That means you are sitting in a position we do not have normally breathing difficulty. Now, sitting in the place, if you have a breathing difficulties, that particular clinical thing or clinical entity, we call them as dyspnea. So, during if you have a breathing difficulty, we have to recruit extra muscles. So, that particular extra muscle increase moves this particular chest wall movement. When you go to the clinic, you will see this kind of persons who are suffering from kind of lung disease, some kind of heart disease. They are having this kind of breathing difficulty. So, they are sitting, but while in a sitting posture, they are recruiting the extra muscles like pectoralis major, scalene muscles. So, this kind of extra muscle execution is going on in a sitting posture. We call that clinical condition as dyspnea. That thing happens in case of heart disease, in case of the lung disease, asthma, COPD, like those kind of clinical thing, where if you have highest movement of the diaphragm, highest movement of this particular thoracic muscle movement is going on. So, in physiology, you will be following and doing this particular respiratory movements again in physiology, you will see this kind of respiratory movement change as well whenever you are studying this. So, this chapter is done with us with this intercostal space and but we are not done yet. Don't pack your bag right now. We have to cover this particular content as well. Unless until we enter to this, we cannot start the dissections. So, take a breather, 2 minutes, sleep a little bit, take a nap, what she is doing for a long time, dream something, think of some good foods you are eating or sitting out here. It's a only boundary thing which is going to be taught. But the thorax is very intense, very short course which you have, but it is very related to clinics. So, once you break this thoracic wall, the ribs and everything, tear these things apart, we land up into a space inside this particular thoracic wall. So, this particular inside thoracic wall, we have the cavities. So, we call them as thoracic cavities. This thoracic cavity is split into two parts. Right side and left side, we have two lungs, which is placed within this particular covering of the lung, we call them as pleura. So, this particular pleura, we call them as pleural cavity, right side pleural cavity, left side pleural cavity. Now, if this lung is taking this lung side, right side and left side of it, we are only left with the middle portions of this particular thoracic wall, which is called as mediastinum, which is complex or intense, which is going to be this study. So, this is what we are going to see. So, if you cut this particular individual a section and look from the top, this thorax looks like this. So, the right side pleural cavity, left side pleural cavity, they are occupied by the lung, and in between this particular space, we have these particular extensions of the space front to back. This one we call them as mediastinum, which we are going to study. Now, this particular mediastinum is easiest to study. Now, thing is that we divide this particular mediastinum into segments or parts or subdivide and make this thing smaller and large each of the segments. Now, let us try it. So, this particular mediastinum in the middle space, which is present in here, is taken from the sides of the individual, and this particular mediastinum extension of it, that means how much this mediastinum can be called as mediastinum or mediastinal spaces. So, it is related to this mediastinum on the top, above and below. So, below it is covered by the diaphragm. So, the diaphragm is the lower limit. Above is the superior thoracic aperture. Remember that we talked about it. So, this superior thoracic aperture or thoracic inlet is present in here as a superior quadrant. Now, this above to below this space is there. In the front we have this particular sternum, the whole length of it. Back side we have the vertebra covered, and the sides we have these ribs along with this lung pleural cavity, which is present on the lateral extremities. So, this is about the boundary of the space defined we are going to talk about. Now, this particular mediastinum space vertically this particular length from here to here can be split into two parts by drawing a horizontal line starting from the sternal angle. So, you know the sternal angle where this particular Manubrium sterni joins with the body of the sternum. So, this particular union point where the second rib fits in, we call them a sternal angle or angle of Louis. So, that particular line from here, from the sternal angle at the level of the second rib, if we draw a vertical line going back, dropping into vertebral column that joins over here in the vertebral T4 and T5 at that junction, we get a division done. Above this particular sternal angle, we get this space, we call them as superior mediastinum. Below here, we have this inferior mediastinum. Now this inferior mediastinum, the central part of it is occupied by the heart with this covering, we call them as pericardium. So heart with pericardium and great vessels which is placed in this middle of this inferior mediastinum splits this place into anterior mediastinum, heart and pericardium into this middle mediastinum, and behind this heart and pericardium we call them as posterior mediastinum. So once again, subdivisions. Entire length we call them as mediastinal space. The mediastinal space is split into half, above and below, superior, inferior by sternal angle. Below one inferior, above the sternal angle superior. Now the inferior one can be subdivided anterior to posterior 3. Heart is in the middle, splits this anterior to the heart as anterior mediastinum, posterior to the heart, posterior mediastinum. The heart itself is the middle mediastinum. Clear? So this is the entire space, this is the subdivision. Superior mediastinum, inferior mediastinum by the sternal angle, inferior mediastinum, anterior part of the inferior mediastinum, middle part of the middle mediastinum, posterior part of this. So number 2, number 3, number 4. So number 2 is anterior mediastinum of inferior mediastinal spaces. Number 3 is the heart with the pericardium which is occupying here, middle inferior mediastinum. Number 4 is behind the heart, the content is there, we call them as posterior inferior mediastinum. Clear? So this mediastinum and subdivisions of the mediastinum, the extent of the mediastinum, how they are there, boundaries of it are your exam questions. So define what is mediastinums, discuss about the subdivisions of the mediastinum. That means 1 plus 2 is your exam question likewise. So this much only you get 3 mark questions out here, whatever you are studying. Now what we have to do out here, once you know this particular mediastinum, the subdivision is there, it is occupied by packing of some kind of neurovascular structures again. So you will have some viscera or organs, will have some kind of like a nerve vessels, etc., present in here, and you have to know exactly what precisely placed in this particular mediastinal spaces. That's what we are going to do for these classes. So we take this particular superior mediastinum, we restrict this particular mediastinal descriptions or discussion up to this content of superior mediastinum only for the day. Next day onwards we will talk later on, okay. As I look, you are kind of like super depressed. So the deal is superior mediastinum. I am not going to talk anything beyond that. So we understand the boundary of the superior mediastinum. The lower boundary of the superior mediastinum is the sternal angle. The superior one is inlet. Anteriorly, Manubrium sterni. Posteriorly, the thoracic vertebra 1, 2, 3, 4. Get the space? On the side, the pleura of the lung or pleural cavity. Clear? The space 3-dimensional you are imagining. So laterally, right side lateral, left side lateral, we have the lung with the pleura. Anteriorly, we have this sternum. The sternum of it, the upper part of the sternum we call the manubrium, which is present in here, Manubrium sterni. Back side we have the vertebra. Vertebra means thoracic vertebra. Thoracic vertebra, we have 12 thoracic vertebra, 1, 2, 3, 4, they are there present on the back side. And inner limit, upper limit, thoracic inlet, lower limit is the sternal angle, that particular horizontal imaginary line. That's it. So this particular superior mediastinum is fitted with some structures that we are going to talk. What structure lying within this particular superior mediastinum between this particular space? We call them as content of the superior mediastinum. This is also your exam question. So this picture you have to keep in mind. What present in here is basically this picture. If you remember this picture, you can answer them. Alright? So once with everything open out, you see this one is lung. This one is lung with this white shadow is covering of the lung. We call them as pleura. And this particular space we are going to talk. We are not going to talk about lungs or this one. So this particular space is entire length is that mediastinal space. Now you can imagine we are going to talk about the superior mediastinum. That means we are somehow talking about something like here and the content above it, not this content which is lying below. So this particular heart and everything is lying below, is inferior mediastinal content, and this thing which is present above, which is the point of concern for this. So
if you take these things out, we are going to see one structure which is present in here, which is your fatty tissue which you are seeing here. It's a kind of gland which is present. We call them as thymus. Thymus is a kind of gland which secretes some kind of like a chemical substance which is of physiological concern. I am not going to take time about it. This particular thymus is an organ which is present for the like kids, young kids. So before we reach to this particular age of 10, we had this much of thymus tissue present. Afterwards, this particular thymus tissue shrinks and replaced with fats. So what we adult people have, we do not have no thymus tissue either, or this thymus tissue is replaced by the fats. So this thymus tissue which you are seeing here is present for the kids before it reaches to the first decade of life. After the first decade of life, it is not more there. So after this particular thymus, we have this particular vessels which is present in here. We have the vessels which is present in here. We call them as brachiocephalic vein. This one is brachiocephalic vein right side, this one is brachiocephalic vein left side. They join together and makes this particular united vein. We call them as superior vena cava. The superior vena cava ends up in here. So this particular superior vena cava is present as a content of it. Now this particular superior vena cava, along with this particular thing, we have some other structures which you have to dig little bit. So here from the heart we have an arch. We call them as arch of aorta. Alright. So we have this particular heart. You see that? This particular heart is projected in here, and from the heart there is a big vessel coming out like this, the red one. We call them as arch of aorta. The arch of aorta begins with this beginning part, we call them as ascending aorta. So heart sends this particular big giant vessel, we call them as ascending aorta, which curves, the curved part we call them as arch of aorta. Then it drops back. We call them as descending thoracic aorta. So this pipe which is coming out from the heart, this one, red one, taking a curvature, ascending part climbs up, we call them as ascending. Then it curves, the curved part we call them as arch. Then it drops back, we call them as descending aorta. So this part which is arching over here, we call them as arch of aorta, is present as a content of superior mediastinum. Now from this particular arch of aorta, there are three branches coming out like this. So we call them brachiocephalic trunk, subclavian artery and the carotid arteries. The branch along with this arch is a content of superior mediastinum. Not this ascending part, neither this descending part. Clear? So what I am emphasizing out here is a precise position of some blood tube or blood vessel. We are talking about a blood tube or blood vessel which is coming from the heart, the left ventricular chamber of the heart, we call them as aorta, which basically pumps the oxygenated blood from the heart for the rest of the body. So this aorta has three different parts. We call them as ascending, climbing part, then it curves, we call them as arch of aorta, then it drops back, we call them as descending aorta. So out of this 1, 2 and 3, the part 2 which is curved part along with the branches which is coming from it is a content of superior mediastinum, not this number 1, neither this third one, alright. So we will be seeing what 1 is coming and 3 in different sections. So this part is coming here. Then another thing which is present next to this, we call them this one. We call this particular part as pulmonary trunk. So this pulmonary trunk which is from this right ventricle goes to the lung to get oxygenated. So a pulmonary artery, we call them as pulmonary trunk, it splits into right side and left side pulmonary arteries that goes to the right side lung, left side lung to bring or to take this particular deoxygenated blood from the right ventricle to the right lung, left lung respectively, and it brings this particular oxygenated blood through the pulmonary arteries, through the pulmonary veins to this particular right ventricle atrial chamber, left atrial chambers. So this particular content of this is important to us. So we talked about this particular thymus which is present anteriorly. Then we have the superior vena cava, and a formative tributary of the superior vena cava is that brachiocephalic veins, so right side, left side joining and then making this vein, we call them as superior vena cava. So superior vena cava is as a content of it. Then we have the arch of aorta and its branches that we are talking about. So these three things we have to really keep in mind regarding to it. Then we have the windpipe behind it, which is visible, trachea. Behind this trachea, we have the food pipe, we call them as esophagus. So trachea and esophagus which is present as a content of it. Then we have some nerves, we call them as nerve which is going to supply the diaphragm as phrenic nerve. So this phrenic nerve present in the anterior aspect, and the deep there we have the vagus nerve which supplies the heart and rest of this particular viscerous organ as well. So vagus nerve and branch of vagus we call them as left recurrent laryngeal nerve. They are contained as a nerve which is present on the content of superior mediastinum. Then we have some kind of tube-like structure, we call them as lymphatic channel, we call them as thoracic duct, and lymph nodes which is related to it as a content of superior mediastinum. So this contents matters a lot because this gives us an orientation of what are the structures is going on. Now why these things matters to us? Because this region related to us is for the surgery is very important. If you have to do any surgeries, like any kind of bypass surgeries or any kind of lung surgeries or any kind of like tissue surgeries which is requiring your introduction to the mediastinum, this content you must be knowing very, very well, and eyes closed you must be able to see what is present in it, or else you will be damaging them, and or else you will be damaging the nerves, or else you will be damaging some kind of blood vessels. So this knowledge is very, very, very important for us to know what content is there in the superior level, middle level, anterior level, posterior level, etc., etc. So we are restricting today's discussion to this particular superior mediastinum and content of it. We learn this particular content which is present in here is some neurovascular structure, some blood vessels are there, and some glands are there. We have a gland, we call them as thymus, which is present in young kids. Then we have the veins, we call them as superior vena cava, brachiocephalic vein. We have the arch of aorta and its branches. We have the trachea and the esophagus and the nerves, phrenic nerve, vagus nerve which is present on it, and a lymphatic channel we call them as thoracic duct. So this particular content is important for us. Now you are happily packing your books, I have no problem as long as you are coming back with proper preparations. So make sure you come back to the next class preparing well whatever the content is learned in the coming week. So we have started the thorax with yesterday classes, we are continuing this and you will be continuing the next week as well. So by the time you reach to next Saturday class out here 10 a.m. you come prepared, because you never know, I may be giving or throwing a surprise exam for you. So Saturday next, whenever you are visiting here, make sure you come prepared. All right. Okay, enjoy the weekend.